Hello and welcome, fellow student doctors. Today, we will discuss lung development. Friends, I can hear your sighs through the computer screen, as this is a challenging topic for many students. When I was assigned production of this video, fear struck me until I researched the topic, designed my lesson plan, and realized that lung development actually has a lot of high-yield associations that are frequently tested. So, instead of memorizing all the minute details, I will prepare you for test day with high-yield associations and hopefully deepen your understanding about and appreciation for lung embryology. We are in for some fun, friends. Let's get started. To prepare you for test day, you will be able to 1. List the 3 periods and 5 stages of lung development. 2. Describe the anatomy and pathologies associated with each stage of lung development. And 3. Explain when breathing outside the womb is possible. Our discussion of lung development will be based on this concept map, which shows the 3 periods of lung development which are subdivided into 5 stages. The stages can be remembered by the mnemonic every pulmonologist can see alveoli, with each first letter representing the embryonic, pseudoglandular, canalicular, saccular, and alveolar stages of development. Friends, you do not need to know the exact time range of all these periods and stages. As you can see in this concept map, the arrows overlap one another, so understanding the general time frame of each stage is important, and I will point out the specific time ranges that you need to know to be successful on test day. Lastly, to just orient you to this figure, you can see the time periods listed at the top, followed by the stages and their associated weeks of development in the middle, with the anatomy at the bottom of what's developing in each stage. We will discuss each of them individually and note the key anatomy, pathologies, and whether respiration outside of the womb is possible at each stage of lung development. Let's start by discussing the embryonic period and embryonic stage of lung development. As background, embryologists denote 3 time periods for embryonic development. The germinal period between 1 to 3 weeks, which includes fertilization of the egg and implantation in the uterus. Next, the embryonic period, pictured here, from 4 to 7 weeks is where organogenesis occurs. This is a fancy term to mean organs start growing. Here, the lungs start growing. High yield, high yield, high yield is to know that during the embryonic phase, the embryo is highly susceptible to teratogens, which can alter organ development. Step 1 commonly asks this, so repeat after me. The embryonic period of development is when organogenesis occurs and the embryo is most susceptible to teratogenic damage of developing organs. Got it? Good. Next, the fetal period occurs from 8 weeks till birth and involves the growth and differentiation of the organs that began to develop in the embryonic period. Now, looking at this chart, you can see how the embryonic and fetal periods of development relate to lung development and the included stages. For now, let's just focus on the embryonic period and stage of lung development and discuss each column of this table that you can use to review. Starting with anatomy, the embryonic period starts with organogenesis. So what is the key embryologic derivative of the respiratory tract? The lung bud, which branches off the foregut of the gastrointestinal tract to form all the structures of the respiratory tract. In the embryonic stage, we develop the trachea all the way down to the tertiary bronchi. It is high yield to know that the trachea and bronchi are the only structures in the entire respiratory tract to contain cartilage. Moreover, it is important to understand this embryology in a little bit more detail. So let me show you this image of embryonic development, specifically of the gastrointestinal tract. In green is the pharyngeal arches, blue represents the foregut, yellow the midgut, and orange the hindgut. Off the foregut in blue, where the esophagus begins to develop, represented by the E, a bud forms, the lung bud. Eventually, a septum will form that separates the lung bud in purple from the esophagus in blue, so a separate esophagus and respiratory tract can form. if the septum does not divide the lung bud, which branches off the embryonic foregut where the esophagus develops properly, we get pathology, called a tracheoesophageal fistula, as you can see in this image. The arrows show where the septum did not divide the lung bud and future respiratory tract from the esophagus correctly, leading to a tracheoesophageal fistula, whose clinical features briefly include air in the stomach, shown at the bottom of the image because the respiratory tract is connected to the gastrointestinal tract, filling it up with air. Similarly, patients get aspiration pneumonia, as gastrointestinal contents can reflux directly into the respiratory tract due to the fistula. Finally, in the case of the right side of the image, if there is esophageal atresia with the tracheoesophageal fistula, then the provider will not be able to relieve the air in the stomach with a nasogastric tube because the esophagus is atretic or not formed and ends in a blind pouch. So expect drooling, choking, and vomiting of secretions and food as they cannot pass into the stomach. Surgical correction will be needed. The next condition we need to discuss is the formation of a bronchogenic cyst that are characterized by having cartilage. Oh, our friend cartilage is back. Let me tie this all together for you using this diagram. In purple, coming off the blue foregut where the esophagus, represented by the letter E, develops, is the lung bud that forms the entire respiratory tract, as we have discussed. In some people, an additional lung bud forms off the foregut and develops into a bronchogenic cyst. Interestingly, a bronchogenic cyst does not have any connection with the first lung bud and develops as just a ball of lung tissue in the mediastinum with no functional role. Importantly, the bronchocytic cyst contains cartilage and respiratory epithelium. The presence of cartilage is important because it helps you remember the embryology. During the embryonic stage, the trachea and bronchi are formed. This is key because they are the only respiratory tract structures to contain cartilage. The rest of the respiratory tract does not have cartilage. Since a bronchogenic cyst can form during the embryonic stage, they have cartilage. This is also important because cartilage can be seen on X-ray, and so bronchogenic cysts are on the differential diagnosis for a lung mass because they are very common, with up to 1 out of every 42,000 chest X-rays showing a bronchogenic cyst. Overall, the key pathologies of the embryonic period of lung development to know include the tracheoesophageal fistula and the bronchogenic cyst. The tracheoesophageal fistula is very high yield, so make sure you check out our GI section for more information on that. Now, to answer our last question in this table, breathing is not possible if the baby was born at this stage because there are no alveolar structures available for gas exchange. We only have a trachea and bronchi formed. While this sounds obvious, step 1 sometimes asks you, at what stage of development is breathing possible outside of the womb? That would be the canalicular stage, which we will cover in a few slides. For now, here is a completed table for you to study or make an Anki card out of. Overlapping with and continuing after the embryonic period and stage is the pseudoglandular stage, which, along with 2 other stages, is part of the fetal period of development, which is characterized by continued growth of the organs formed in organogenesis in the embryonic stage. Focusing on the pseudoglandular stage, let's begin to fill out our table. In terms of anatomy, recall that the embryonic stage took us from the lung bud to the tertiary bronchi. Say it with me. What makes a bronchus is that it has cartilage. Friends, that is where cartilage ends in the respiratory tract. There will be no more structures with cartilage. Next, you may be wondering why this is called the pseudoglandular stage. Well, pseudo means false and glandular means gland. So we have false gland-like appearing structures called the endodermal tubules. When we think of the endoderm, we think of the GI tract epithelial lining, don't we? Well, the respiratory tract budded off of the GI tract, didn't it? Remember the lung bud from the last slide? So, since the respiratory tract is intimately tied with the gastrointestinal tract, endodermal tubules form, which begin to create the respiratory tract epithelial lining, which resembles the glandular epithelium of the GI tract from which the respiratory tract branched off of, hence the name pseudoglandular. Moving on, those endodermal tubules give rise to all the structures down to the terminal bronchioles, which lack cartilage along with a modest capillary network. Now, repeat after me, friends. What makes a bronchiole is the absence of cartilage. With the formation of a vascular network in this stage, it is also important to realize that pulmonary vascular resistance is high, so blood is shunted away from the lungs. Why is this? Well, the developing lungs lack alveolar structures that can participate in gas exchange, so blood must be shunted away. To accomplish this, the lungs are filled with amniotic fluid, and they are also hypoxic in utero, leading to vasoconstriction. In terms of pathology, this stage can set in motion Potter sequence, which is a sequence of events that leads to pulmonary hypoplasia, meaning poor growth of the lungs. This makes sense because we are in the fetal period of development where organs are growing in size. So if Potter sequence occurs, the lungs will not grow in size, resulting in pulmonary hypoplasia. How does this happen? Well, at 10 weeks of development, the baby inhales amniotic fluid as shown by the green arrow entering the baby. This mechanically stretches the developing lungs and stimulates their development. Let me show you. The lungs are represented by the bubble. So when the baby inhales amniotic fluid, it stretches the lung and stimulates mechanical development of the lung, and so this process is repeated over and over while the baby develops in utero, ensuring proper development of the lungs. So, if the baby experiences oligohydramnios for any reason, which is low amniotic fluid levels, Potter sequence can occur because the lungs will not be mechanically stimulated to develop. Moreover, Potter sequence can be remembered based on each letter, with the P standing for pulmonary hypoplasia, O for oligohydramnios, which is the trigger as the bubble sequence below demonstrates. Moreover, the T's stand for the twisted face and twisted skin as the baby floats in amniotic fluid, and without it, the face and skin rub up against the uterus and placenta, leading to deformities. This outside pressure, without the presence of proper levels of amniotic fluid, explains why extremity defects are also seen, such as mandibular hypoplasia, as demonstrated by the arrow in this picture. Lastly, the R stands for renal failure, which is a cause of Potter sequence, as the baby's kidneys are responsible for making urine, which constitutes the majority of amniotic fluid in utero, as this image shows by the yellow arrows. Overall, the causes of Potter sequence center on what cause oligohydramnios, which can result from placental insufficiency, meaning the placenta cannot deliver blood and nutrients to the baby for its kidneys to make urine. Similarly, if the baby has renal issues, the fetal kidneys cannot make urine, which constitutes the majority of amniotic fluid, leading to oligohydramnios. Some people like to think of the P and R in Potter to remember P for placental insufficiency and R for renal failure. Lastly, it is not possible for the baby to breathe if they were born at this stage, as no alveolar structures exist for gas exchange. We only have terminal bronchioles in the pseudoglandular stage. Overlapping with and continuing after the pseudoglandular phase, within the fetal period, is the canalicular stage. Again, the fetal period is characterized by continued growth and development of the organs formed during the embryonic period. So let's continue that conversation by adding on to the anatomy formed in the previous stages. In the canalicular stage, respiratory bronchioles that lack cartilage form and extend all the way down into the alveolar ducts that have a prominent capillary network. This is a big stage of development, isn't it? Because we are getting close to gas exchange. With development of the respiratory bronchioles, we have now our first structure capable of gas exchange, as respiratory bronchioles have alveolar outpouches where gas exchange can occur, hence why they are called respiratory bronchioles. Additionally, the alveolar ducts and capillary network further enhance the possibility for gas exchange if the baby is born prematurely. So, respiration becomes possible at the end of the canalicular stage once these structures continue to mature. To remember this high yield fact, use the mnemonic "the baby canalicular breathe" at 25 weeks of development. In terms of pathology, this stage is a continuation of the pathology of the pseudoglandular stage in that pulmonary hypoplasia can occur. I'll make this simple for you. There are 3 stages in the fetal period. The fetal period is a time of organ growth, lung growth here, so pulmonary hypoplasia or poor growth of the lungs can occur in all 3 of the pseudoglandular, canalicular, and saccular stages of development that occur within the fetal period. In contrast, the embryonic stage is an all or none. Either the lung bud develops or it doesn't. That would be aplasia or without growth in that situation. This is very high yield for exams, so make sure you understand that. Anyway, let's add on another cause of pulmonary hypoplasia beyond Potter sequence and discuss a congenital diaphragmatic hernia. Essentially, the diaphragm acts as a lid and seals off the chest cavity from the abdominal cavity. If the diaphragm doesn't form correctly, the abdominal contents can herniate up into the chest cavity, which is called a congenital diaphragmatic hernia. Why does this occur? Due to a defect in the pleuroperitoneal membrane. Repeat with me, pleuroperitoneal membrane. That will be on your exam, pleuroperitoneal membrane. Essentially, pressure-induced atrophy of the developing lungs occur from the abdominal organs pressing on them, leading to pulmonary hypoplasia. Next, it is important for you to know that pneumocytes develop in this stage, as shown in this histologic image. The type 1 pneumocytes mainly participate in gas exchange, whereas type 2 pneumocytes have 2 key functions. They are stem cells for cells of the lung, and they produce surfactant, a key substance that enables gas exchange to occur as it keeps alveolar structures from collapsing due to surface tension. Looking at the far left image, the pink slanting graph depicts increasing surfactant levels. Lastly, as you know, breathing is possible if the baby is born, as alveolar structures are present and mature enough at the end of the canalicular stage. Just remember, the baby canalicular breathe at 25 weeks of development. Overlapping with and continuing after the canalicular stage within the fetal period is the saccular stage. Again, the fetal period is characterized by continued growth and development of the organs formed during the embryonic period. So let's continue that conversation by adding on to the anatomy formed in the previous stages. So the saccular stage extends the alveolar ducts into, you guessed it, sacs, primitive alveoli, called terminal sacs with primary septa. We'll discuss septation later. Moreover, the capillary network for gas exchange is expanding. Looking at the image on the left, this stage starts with an S because sacs are formed and because surfactant production increases dramatically. This sets up the pathology associated with this stage of development, deficiency of surfactant. This graph shows the concentration of surfactant along weeks of gestation, just like the graph. The graph in the center shows the high-yield lecithin L to sphingomyelin S ratio. I will be calling this the LS ratio. Both molecules make up surfactant, but once the type 2 pneumocytes mature with enlarging lamellar bodies, they begin to secrete predominantly lecithins to compose surfactant. So, physicians can sample amniotic fluid to compare the LS ratio, and once this ratio is 2 or greater, the baby is deemed at low risk for NRDS, neonatal respiratory distress syndrome. However, if the LS ratio is less than 1.5, the baby is considered high risk for NRDS. Why? Well, deficient surfactant levels, specifically surfactant made mostly of sphingomyelin, not lecithin, so a deficiency of mature surfactant levels, you might say, leads to increased surface tension on the alveoli of the lung, so they collapse, and a collapsed alveoli cannot perform gas exchange effectively. So the baby enters NRDS, neonatal respiratory distress syndrome, with the collapsed lung segments leading to a ground glass appearance on X-ray as shown here. This predisposes the baby to significant morbidity and mortality. The underlying cause of NRDS, whether it be from prematurity, maternal diabetes, or a C-section delivery, is due to the relative lack of mature surfactant made of lecithin, which are produced from what cell type? The type 2 pneumocyte, and in what organelle? The lamellar bodies. Nice. Lastly, breathing is certainly possible at this stage as alveolar structures are present. Respiratory bronchioles, alveolar ducts, and terminal sacs, primitive alveoli, are all present. Overlapping with and continuing after the saccular stage, ending the fetal period, is the postnatal period and alveolar stage. The baby has been born. Woohoo! Happy birthday to you, happy birthday to you. Moreover, the lungs continue to develop after birth. So let's continue that conversation by adding on to the anatomy formed in the previous stages. Those terminal sacs mature into more mature alveoli, such that 1/3 of all the alveoli a person will have in their lungs are developed at the time of birth through a process called secondary septation, which we'll discuss on the next slide. Septation is important because all the way until 8 years of age or beyond, septation keeps occurring, increasing the surface area in the lung for gas exchange. Let me show you. To explain septation, also called alveolarization, let's compare the saccular stage to the alveolar stage of development. The saccular stage has terminal sacs, which are primitive alveoli. Represented here with this figure where the black lines represent areas capable of gas exchange. So, if the child were born and tried to breathe, air would come into the terminal sac like this, but would have a low surface area available for gas exchange. However, as the baby's lungs continue to mature through the process of septation in the alveolar stage, the surface area for gas exchange would greatly increase. It is called septation because that one big terminal sac on the left is septated into many compartments capable of gas exchange. So, when air enters the alveolus, there is much more surface area for gas exchange. Overall, this process of septation or alveolarization occurs up to and even beyond 8 years of age. If this process does not occur properly, then we may develop bronchopulmonary dysplasia. Let's address that in more depth on the last slide. Bronchopulmonary dysplasia, listed in the middle column here, occurs due to a sequence of events. For example, a preterm infant's septation is underdeveloped, so they may develop NRDS, neonatal respiratory distress syndrome, as their lungs cannot efficiently perform gas exchange. To sustain their life, they would be treated with oxygen and mechanical ventilation. You must understand that oxygen is a drug when it is administered in the healthcare setting, as it can create free radical damage. Additionally, mechanical trauma to the lungs occurs due to ventilation, ultimately leading to dysplastic or abnormal septation of alveoli and ultimately bronchopulmonary dysplasia. This causes respiratory problems and increased respiratory-related morbidity and mortality. Fortunately, septation can still occur throughout childhood, even beyond 8 years of age, so children can recover lung function. Overall, it is high yield to know that oxygen therapy in infants can result in RIB, retinopathy of prematurity, intraventricular hemorrhage, and bronchopulmonary dysplasia. Lastly, breathing is of course possible due to more advanced alveoli containing structures being present. To finish our discussion, let's bring the anatomical correlations with lung development together on one slide. So, looking at this diagram, what stage of lung development best correlates with this arrow? The canalicular stage, because this begins the respiratory zone where the respiratory bronchioles are first formed and respirations outside of the womb are first possible. Just remember, the baby canalicular breathe at 25 weeks of development. Adding the time periods and stages, the trachea and bronchi are formed during the embryonic period and stage, where organogenesis occurs from the embryonic lung bud. Recall that these are the only structures in the entire respiratory tract with cartilage, as this figure shows with the gray cartilage rings only on the trachea and bronchi. Next, the fetal period is where the respiratory tract increases in size and complexity, with the pseudoglandular stage developing the bronchioles down to the terminal bronchioles, followed by the canalicular stage forming the respiratory bronchioles down to the alveolar ducts, followed by the saccular stage forming the terminal sacs, primitive alveoli. These three stages mark the fetal period. After birth, the postnatal period occurs, where those terminal sacs undergo septation to form more expansive alveoli with increased surface area for gas exchange. Friends, it's time for a flash quiz. The question reads that upon the birth of a full-time baby boy, the infant becomes tachypnic, cyanotic, and exhibits grunting and nasal flaring with every attempted breath. He is immediately taken to the neonatal intensive care unit where this X-ray is taken. What embryological structure likely was defective in development leading to this presentation? A. Pleuroperitoneal membrane. B. Parietal membrane. C. Respiratory diverticulum. Or D. Zenker's diverticulum. The correct answer is A. The pleuroperitoneal membrane. In this image, you can see darker, translucent areas in the chest cavity. This is herniated bowel from the abdominal cavity in the chest cavity. That, as you would imagine, is a big problem. This requires surgery, and the baby would be in significant respiratory distress as the lungs are hypoplastic or poorly formed due to pressure atrophy, with this condition being possibly fatal. All of this occurred due to a defect in the diaphragm, the lid that separates the abdominal cavity from the chest cavity, from a defect in the embryonic structure called the pleuroperitoneal membrane. Its name gives away the answer because pleural means pleural space, where the lungs are, and peritoneal refers to the abdominal cavity where the gastrointestinal tract is present. Hence, the membrane separating the two is defective. The pleuroperitoneal membrane is defective. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. When studying embryology, always keep the big picture in mind. For the embryonic stage, it is high yield to know that the respiratory tract begins as a bud off of the embryonic foregut of the gastrointestinal tract. The lung bud, which goes on to develop all the structures of the respiratory tract. In the embryonic stage, the trachea all the way to the tertiary bronchi are formed. These are the only structures in the entire respiratory tract that have cartilage, a high-yield fact to know. Errors at this stage can result in a tracheoesophageal fistula with or without esophageal atresia, which makes sense because the lung bud comes off of the gastrointestinal tract. Additionally, bronchogenic cysts, which by definition have cartilage, which makes sense because they are formed during the same time as the trachea and bronchi, can form as an error during this stage in development. Next, the pseudoglandular stage begins the fetal period of development, where the lungs grow in size and complexity, with the endodermal tubules resembling glands at the gastrointestinal tract where the lung bud forms from, hence the name pseudoglandular, into terminal bronchioles. Errors at this stage can occur in any stage of the fetal period and involve pathologies restricting growth of the lung. Causes of pulmonary hypoplasia, such as Potter sequence from fetal renal issues or placental issues leading to oligohydramnios, or a congenital diaphragmatic hernia due to a defect in the pleuroperitoneal membrane. Next, the baby canalicular breathe at 25 weeks of development. And that is what marks the canalicular stage of development, as the respiratory bronchioles and alveolar ducts form, along with type 1 pneumocytes who perform gas exchange and type 2 pneumocytes who produce surfactant and serve as stem cells. In the last stage of the fetal period, the saccular stage, terminal sacs form, primitive alveoli, with poor septation. Surfactant production continues to increase, with a lecithin to sphingomyelin ratio being used to screen for lung maturity. If surfactant production rich in lecithins is deficient in this stage, the baby is predisposed to developing neonatal respiratory distress syndrome. Lastly, the alveolar stage in the postnatal period continues the process of septation of alveoli to increase surface area for gas exchange. If septation is dysplastic, bronchopulmonary dysplasia can occur. Friends, if you enjoyed this lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there is a great big beautiful tomorrow.